So we have a 52-year-old man. He come to emergency department due to shortness of breath and dry cough. He has been feeling weak over the last several days. Some dyspnea or exertion is there, and he woke. Now today morning he woke up with persistent breathing difficulty, and he come to emergency department. There is a mild history of intermittent asthma, for which he uses occasionally albuterol, which is a beta 2 agonist. Well, at the moment, his BNP level are increased on a lab investigation. Now, which clinical sign would be best correlate with this finding in this patient? Well, the answer is third heart sound. Why this the answer? Well, as far as patient clinical presentation is consistent with CHF, although he has a breathing difficulty and he is a known case of asthma, but now this breathing difficulty is due to congestive heart failure. It is a progressive dyspnea over days, fatigue, and the most important is elevated BNP level. This is the I think most important criteria among all what is mentioned here, because these are non-specific, they can occur in other conditions also. Now, as far as BNP is concerned, it is a natriuretic peptide. It means it causes loss of sodium and water in the urine. So it more of a natriuresis causes a loss of sodium. It releases from the ventricle myocyte in response to. Remember, BNP is related from ventricle, and we have one more molecule ANP which come from atria. So this from atria and BNP from ventricle myocyte. Now, why? And they are released in relation to high ventricle filling pressure and wall stress in congestive heart failure. And we are well aware in this congestive heart failure, there is left ventricle and diastolic volume is increased, and that lead to increased length in the sarcomere also. Now, as far as BNP is concerned, it is derived from prohormone pro-BNP, which break down and produces active BNP and inert N-terminal pro-BNP. So we can say pro-BNP, this molecule, break down into BNP plus anti-pro-BNP. This is an active compound, active component, and this is inert. That means, but it will be equimolar, both will be equimolar. That point you have to take into consideration. So that's why elevated level of circulating BNP or anti-pro-BNP, remember both, they are equimolar, they are all derived from pro-BNP, correlate with the severity of left ventricle systolic dysfunction. Okay, that means if there is left ventricle failure is there, left ventricle dysfunction is there, and that will cause increased release of BNP. And moreover, high negative predictive value for CHF as a dyspnea, if normal values are there, then perhaps this is not a case of congestive heart failure. Now, the third sound is a low frequency diastolic sound. It is heard best over the cardiac apex in the left lateral decubitus position. Well, now I have a question for you. S3 is produced in which phase of cardiac cycle? Write down the answer. Well, it is produced in early diastole. Little bit basic concept. This is the heart, and this is the valve, mitral and tricuspid valve. In early diastole, the valve open. Rapidly, blood will enter into the ventricles. 70% of the blood from the atria enter into the ventricle. Both atria, respective ventricles, 70% blood come. And this is early diastole. This is also known as rapid filling phase of myocardium. Okay. Normally no sound is produced, but if a sound has to produce, then it is third sound. That means third sound is produced in the early diastole or in the rapid filling phase of myocardium. That's why S3 is also known as filling sound. And near the end of diastole, the atria will contract and that will produce next 30% of the blood into the ventricle. And that's why atrial contraction is called as atrial kick. And normally during atrial contraction, no sound is produced. But if a sound has to be produced, that will be S4. So that's why S4 is also known as atrial sound. But now I have two questions for you. In JVP, what wave will we see in early diastole and which wave we see in late diastole? Write down the answer of these two questions. Answer is Y descent and A wave. In other way around, we can say Y descent correspond to third sound and A wave correspond to S4. With this background, we come back about third sound. Okay. So S3 is produced by the passive ventricular filling during the early diastole. Why passive filling? Because S4 is produced due to active atrial contraction. It is just simply ventricle is dilating. And this can be now one more question for you. Write down the answer in your copy. S3 can be produced in a normal person also. Who are those normal person? It can be heard in children, pregnancy, athletes. This can be produced. Now, as far as abnormal S3 is concerned, it is heard in congestive heart failure due to left ventricle systolic dysfunction. It has got 99% specificity is there. It correlates with the elevated left atrial or ventricle filling pressure. An elevated BNP level, and BNP level are elevated due to CHF, the point I already mentioned to you. Now let's look into other option. Cyanosis is incorrect. But this can occur in so many lung disease also, and the most common cause of cyanosis is chronic bronchitis. It can be heard in congenital heart disease where we have right to left shunt like Eisenmenger syndrome or tetralogy of Fallot. But it could be rare. It is very rare in CHF unless in very advanced stage of CHF. Otherwise, cyanosis is not a feature. And cyanosis will not correlate with BNP level. Very obvious. This is specific for congestive heart failure. Extremity edema is a feature of CHF and is due to volume overload. But as compared to S3 is total less specific and it never correlates with BNP level. S3 correlate with BNP level also. Moreover, edema can be seen in inferior vena cava obstruction, cirrhosis of liver, lower extremity venous insufficiency or nephrotic syndrome, or any condition which lead to hypoproteinemia. In all these conditions, edema feet can be there. Neck bruise is present in patients with carotid artery stenosis that we can diagnose by Doppler study. It has nothing to do with congestive heart failure or BNP or third sound. Periumbilical bruise we can hear in renal artery stenosis. And this is usually maybe in young ladies or elderly, they usually manifest with hypertension. But definitely it has got nothing to do with third sound or heart failure. Golden line to remember, elevated BNP level and audible third sound are sign of increased intracardiac filling pressure. They are noted in patients with CHF due to left ventricle systolic dysfunction. So we have a 57-year-old man. He come to you with progressive worsening fatigue, difficulty in concentrating, increasingly forgetfulness for the last several weeks. Right upper abdomen weight pain, discomfort, constipation, gained weight in the last 3 months. There is hypertension, non-ischemic cardiomyopathy with left ventricle systolic dysfunction is a past history. Persistent atrial fibrillation. At the moment, BP is 160 by 100 high. At the moment, pulse is 58. And lung fields are clear to auscultation. There is no ankle edema. Skin appears dry. Lab reports, you can see that these liver enzymes are slightly raised. Is the main thing that we are getting in this patient. Well, the question is, which of the following medication side effects are most likely responsible for this patient complaint? The answer to this question is amiodarone. Well, amiodarone is indicated for patients with serious ventricular arrhythmias, rhythm control in those patients with atrial fibrillation, underlying left ventricular systolic dysfunction, especially in the setting of systolic dysfunction. Like in our case, the question, patient is already a known case of cardiomyopathy and the patient has atrial fibrillation. Perhaps he was giving amiodarone and that has really resulted in control of the heart rate also. But don't forget there is associated bradycardia at the moment and hypertension is there. Well, the patient also, this symptom are due to amiodarone-induced hypothyroid. What are the points which are favoring? Fatigue, memory loss. Look, he had a forgetfulness. Constipation, weight gain, dry skin, bradycardia, pulse 58, and hypertension is there. They are the two features which are due to hypothyroid. Okay. And he also shows signs of some hepatocellular injury because the liver enzyme, both the liver enzymes, the value is much higher. Well, when we are using amiodarone for a long time, it can induce multiple organ failures or disturbance can be, to be more precise, multiple organs are affected. And 50% of the patient, it's a huge percentage of the patient who are on amiodarone therapy can develop one or other side effect, and even the dropout rate is very high, 1 out of 5. That means 20 out of 100, 20% will drop out. They will not continue with amiodarone because of one or other side effect. So that is a serious concern about amiodarone therapy. Now, whenever a patient is on amiodarone therapy, you should monitor thyroid function tests periodically. Why? Because they can lead to both hypo and hyperthyroid. Like in our case, the patient of the question, the patient has developed all the features of hypothyroid. Hepatic function marker like liver enzyme are raised in this case also. Suspicious pulmonary symptoms should be evaluated with chest X-ray and pulmonary function tests. And some visual disturbance can also be there in this patient. So that means eye checkup should be done periodically. So periodically thyroid checkup, liver checkup, kidney and lungs checkup and eye checkup are some of the important things that you got to do periodic checkup. Now I got certain questions. Write down the answer in your copy. What the most common pulmonary complication of amiodarone therapy? What the eye complication? What the skin complication that can be seen in case of patient on chronic amiodarone therapy? Write down the answer. As far as pulmonary complication is chronic interstitial pneumonitis. Eye problem, it can lead to corneal deposition. Skin complication, it can lead to blue-gray skin. I'll show you the photograph in the coming slides. So there are some of the complications that has to be monitored. Now the other option are digoxin is the B option. Digoxin can cause a lot of complications like earliest are anorexia, nausea, vomiting, diarrhea. Nausea, vomiting, diarrhea, anorexia are the earliest side effect of digoxin toxicity. Confusion, visual disturbance can be there, and variety of arrhythmias can be there. Thyroid and hepatic function side effects are not seen. Well, I have got two questions for you. Write down the answer. Digoxin toxicity can lead to all types of arrhythmias or blocks. Okay. Now there are two things which usually do not happen with digoxin toxicity regarding blocks and arrhythmias. What are those two conditions which do not happen in digoxin toxicity? Write down the answer. Well, the answer is two things never happen. One is 2B block. Okay, 2B block doesn't happen, and atrial flutter does not occur. These are two side effects which do not occur in digoxin toxicity. Well, the option C is again not correct. Dafotilide is a class 3 antiarrhythmic agent, and the risk of toxicity point is up to 3% of the patient, and the side effect mentioned in the question, they are not the feature of dafotilide. Now again I have a question for you. Write down the answer. Why there is increased risk of toxicity point is in patients who are on dafotilide therapy? Write down the answer. The answer is this is a class 3 drug, and one of the class 3 drug feature is they lead to prolonged QT interval. So any drug which will prolong QT interval is prone to toxicity points. Hydralazine is an antihypertensive drug. It can cause salt and water retention, peripheral edema, palpitation. It can lead to orthostatic hypotension also. And a very commonly asked question is, it can induce drug-induced lupus-like condition. Okay. Well, there are at least more than 50 drugs which can lead to SLE-like feature. But do not forget HIP, hydralazine, INH, procainamide. There are 3 drugs that you should never forget which are very, very important, which can lead to SLE-like feature. Now I have one more question for you. Write down the answer. There's something common in the metabolism of these 3 drugs. What is that thing common in the metabolism of these 3 drugs? Write down the answer. Well, the answer is these 3 drugs are slow and fast acetylated. Okay, and this side effect is more common in those who are slow acetylated. Well, the next option E is metoprolol, incorrect. The major side effect of beta blocker is a beta blocker. It can lead to bradycardia, worsening of heart failure, bronchoconstriction, fatigue, depression, weight gain, and sexual dysfunction are the side effects which can be done by the metoprolol. Write down the answer. I have one more question for you. Recently, a new drug has been introduced, which act on the funny sodium channels. And this drug leads to bradycardia. What is that drug? Write down the answer. Answer is ivabradine. Ivabradine is a new drug which causes bradycardia, and it acts on the funny sodium channels. Well, the golden line to remember, the major side effect of amiodarone. This you should know fully. Invariably, whichever exam you write in the world, you are bound to get a question on major side effect of amiodarone. It can lead to cardiac, bradycardia, and heart block. Pulmonary chronic interstitial pneumonitis is the most common pulmonary problem. Endocrine hypo and hypothyroid, very frequently asked question. In this question also, it was mainly of hypothyroid, but don't forget it can even lead to hyperthyroid also. GIT, elevated transaminase or hepatitis, that is more of a hepatotoxicity is there. Little bit of constipation can occur. Ocular corneal deposit and ocular neuropathy, optic neuropathy. Blue-gray skin discoloration you can see. And finally, peripheral neuropathy is the problem that can occur in CNS. So they are all the side effects that you should remember. Well, I hope you liked the session. Just to inform you, we have following courses for you. Smart Medicine, there are 350 hours of pre-recorded video lecture of whole internal medicine. It includes all super specialty and allied subject, covering A to Z, including basic concept about every topic. Second, we have tests and discussion. There are more than 1,000 questions with discussion of the questions, sample question and discussion you saw in this session. Now, third thing is Medicine Simplified, which is a textbook of medicine. Harrison is the ultimate book to read medicine, but it is too vast. Reading one page of Harrison, you need half an hour. To understand, you need 2 hours, but you need only 2 minutes to forget what was written in that page. Then what is the solution? We have Medicine Simplified. It's a textbook of medicine, but so-called mini Harrison. It's a summary of what you need to read from Harrison. The book is available in Amazon also. Now, these 3 things are more than enough for your MD, DNB Medicine and Family Medicine final exam preparation, NEET SS exam preparation. You don't need to read any other book. These 3 are complete in all the aspects. For more detail, you can contact at this number. It's a mobile as well as WhatsApp. And this is my personal email ID. Anybody want to reach to me, you can contact me at this email ID. Thank you very much.